So hello everybody and welcome to the ESDR Kitchen. My name is Sprecher. I'm from the Department of Dermatology at the Tel Aviv Medical Center in Israel. On behalf of the board and my co-chair, Professor Rajan, I'd like to very much welcome you all to this new sweet and sour episode of our ESDR Kitchen. Just to remind you that the ESDR Kitchen program, as well as previous episodes, are all available on the ESDR website, which, by the way, contains a lot of useful information. The sweet and sour episodes, for those of you who are not yet familiar with this format of our kitchen, are presented by two leaders in their field who are discussing a very controversial topic, each providing one aspect of the discussion. So today we are particularly delighted to have with us two outstanding and very well-known speakers, Lars Iversen and Puig. Professor Lars Iversen is a professor of dermatology at Aarhus University Hospital in Denmark. He received his clinical education and obtained a doctoral degree from Aarhus University. His primary research interest is psoriasis, but he has also numerous publications on cutaneous T-cell lymphomas. Most of his research activities is translational and spans from studies on signal transduction and immunology to clinical studies. Professor Iversen is the co-author of more than 260 articles in leading journals, including Nature Immunology, Nature Communications, and others. Professor Iversen has served as president of the Danish Dermatological Society from 2018 till 2020. In 2018, he was founder of the National Center for Autoimmune Diseases at Aarhus Hospital. And since October 2022, he has also been employed as Chief Medical Officer at MC2 Therapeutics. Professor Luis Puig is a director of the Department of Dermatology, Hospital de la Santa Creu y Sant Pau, and professor of dermatology at the Autonomous University of Barcelona in Spain. For the past 20 years, Dr. Puig has focused on clinical research in the treatment of psoriasis with biological agents. The results of his research have been published in numerous articles and book chapters. He has been board members of the EADV from 2013 to 2019. He's co-chair of the Psoriasis Task Force of the EADV, has been president of the Psoriasis International Network and the Foundation René Touraine Scientific Board Executive Committee till 2020. He's board member of the International Psoriasis Council and member of the GRAPPA Education Committee and Steering Committee. Just before starting, I'd like to mention that this episode is sponsored by BMS. And just also before handing it over to Lars, I'd like to remind you all to forward your queries through the chat or the Q&A functions. Later on, Neil will be very happy to convey all of your questions to our speakers, and this will hopefully ignite a wonderful discussion. So Lars and Luis, thank you very, very much on behalf of all of us for the opportunity to hear you today. We are all very much looking forward to your discussion. The floor is yours, Lars.
Thank you very much for this kind introduction. And what I'm going to talk about the next 10 minutes or so is early intervention in psoriasis and why I think we should use early intervention when treating our patients. These are my disclosures. So I'll start out with a patient case, and this is a patient of mine, Peter. He got his first sign of psoriasis in 1996. It was mild psoriasis at that time, and he was treated with a topical corticosteroid. Later on, 4 years later, he had increased disease activity and he was put on narrowband UVB treatment. Then in 2008, he got psoriatic arthritis and he got more activity in his skin. His PASI was 19, so he was put on systemic treatment with methotrexate. And that lasted until 2016, when his liver enzymes started to increase and methotrexate was stopped, and he came to our department. And you see here at the bottom what he looked like at that time. He had quite extensive psoriasis, so he was put on a biologic. But the major question is, of course, is Peter's psoriasis in 2017 different compared to his psoriasis when it appeared in 1996? We don't know that really, to be honest, but we can look to our colleagues in rheumatology and gastroenterology, and we tend to claim that rheumatoid arthritis and Crohn's disease has a lot of similarities with psoriasis. And they have much more experience in that field. And I'm only going to show you one example on that. If you look at early intervention and treatment response in rheumatoid arthritis patient, this is a publication that came out several years ago. And this is actually based on 14 different trials where they looked at the response in 7 ACR core set items on patients that were put on DMARD therapy. And then they looked at the proportion of responders as the result of disease duration. And as you can clearly see here, there's a much better response if you treat early on in the disease on all 7 core set items of the ACR criteria. So there is an inverse correlation between the disease duration and the treatment response, at least in these rheumatoid arthritis patients. And the same holds true if you look into the literature in gastroenterology. We also have some indications in psoriasis. This is one of our own studies where we made clinical photos of patients that were sent to climate therapy in Israel. And the beauty of this treatment is that they usually get a complete clearance, a PASI 100 response. So we took photos before they were sent to Israel, marked all the areas where they had psoriasis, and then we evaluated patients after they came back to Denmark. And those that had complete skin clearance were asked to show up in the clinic when they started getting the first signs of psoriasis again. And then we marked these small, tiny new spots that they got when their psoriasis came back. And with an overlay, we could easily show that this does not happen in a random fashion. The lesions reappeared in the previous spots, indicating that there may be a molecular scar. So this could indicate that there is something going on over time, that there appears a molecular scar in the skin. And we know that inflammatory memory has been discussed for decades, in fact. And inflammatory memory has been ascribed epigenetic changes or cell-based memory. And for a year ago or so, there was a very nice paper coming out in stem cell, where they showed that these epigenetic changes that happened was seen within the genes, and they showed that when you got an inflammation, you got an activation of a number of transcription factors, including AP1, which is one of these transcription factors. And AP1 is a homo or heterodimer. The heterodimer is Phos and Jun. And what this showed was that in the maintenance, after resolution of the inflammation, Jun remained with other factors as a kind of memory domain. And when you then upon a recall of the inflammation, there was a rapid recall of Phos, which you can see over here. Phos was recruited to the nuclei, and then a reactivation of genes that are transcribed by this transcription factor. So this was one clear documentation of epigenetic changes that could indicate an inflammatory memory. This was not in psoriasis, I should say, but this is a way that this could happen. We also have the cell-based memory. And when we talk about cell-based memory, we have to talk about the tissue-resident memory T cells. These cell types are characterized by expressing cell surface markers like CD69 and CD103. And these tissue-resident memory T cells, they can populate a number of, or almost all tissues in the body, including the skin. And they have also been mentioned to play a role in psoriasis. And with 20 billion memory T cells in the skin is one of the largest reservoirs of this subset of memory T cells in the human body. These TRM cells, they have these cell surface marker, I meant CD103, CD69, sometimes CD49A, and because they're T cells, they have the pan-T cell marker CD3. They, of course, have a protective role. They protect against infections in the skin, but they also, at least there's an emerging literature now suggesting that they play a role, a pathogenic role, as a specific inflammatory memory in various organs. So to make a long story short, what is believed is that these memory T cell precursors, especially the central memory T cells, they are recruited into the skin by chemokines in the early phase of psoriasis. Here they mature, they express the TRM cell surface markers, and when the disease becomes chronic, when you have the chronic plaque, they populate and they increase the pool of these TRM cells, expand, and then they spread out from there into other lesions that appear on the skin. And then the idea is that they can stay there and have or be a kind of disease memory in these previously affected areas in the skin. So one obvious question to ask is, of course, what is the lifespan of these TRM cells? Because if they should serve as a disease memory, they should stay there for a long time. And this was actually studied in a patient that undergoes hematopoietic stem cell transplantation, because here the host and the donor-derived immune cell population could be tracked separately. And the research hypothesis in this study was that maybe these TRM cells, they can reside in the skin without replenishment from the circulating T cells for a long time. What they did was that the patient that should have this hematopoietic stem cell transplantation, they were treated with radiochemotherapy. And as you can see here, they measured the T cells in the blood before radiochemotherapy and after in the blood. And you can see that the host T cells were almost depleted in the blood. Whereas if you look over here in the skin, there was a high number of T cells before treatment, and they were not completely eradicated. There was a significant proportion of the T cells from the host remaining in the skin, despite that these patients had radiochemotherapy. Then the patient were treated with stem cell transplantation, and especially in sex mismatched patients where the donor was different, the sex of the donor was different from the host, you could trace them with XY fluorescence in situ hybridization. And what they found was, to me, very surprising. You can see here that in the blood, there were no host T cells remaining after the transplantation. But if you look into the skin, you can see that the host T cells stayed in the skin, and they could be detected up to 10 years after a patient had a transplantation, meaning that these T cells staying in the skin, they survive for at least 1 decade and maybe decades after. And that could tell us that the tissue resident memory T cells can stay into the skin and keep this memory for years after. So we should avoid these to populate the skin. And this was not only restricted to sex mismatched patients. This was independent of that. So that brings me to my last slide, and that takes me back to psoriasis again. Do we have any evidence? Now I have shown you that there is a possibility that we can induce a disease memory, and that could be an argument that we should intervene early to avoid this disease memory to appear. Do we have any data to indicate that this could play a role in psoriasis? We have one interesting study that also came out a year ago. This is based on the Stockholm psoriasis cohort. Here they enrolled patients from 2001 to 2005, and then 10 years after they were examined by a dermatologist. The same patients were examined by a dermatologist, and they looked at the patient's severity of the patient's psoriasis as the result of when they initiated systemic treatment. And as you can appreciate from this slide here, you can see that those that were treated early on with systemic treatment had less severe psoriasis when they were examined 10 years later compared to those that were treated later on in their disease course. So taken together, I think we can say that time matters. And that's the reason why I'm very much in favor, Luis, that we should intervene early on in this disease, because I think we have a chance to avoid this kind, or at least to diminish the kind of chronicity that we see in this disease. So with this, thank you for your attention.
So the early treatment, it seems to be easier to get the best responses. So nobody is against that. It's difficult, but the hype comes from a background, which is the identification of remission and delayed relapse first in clinical trials. For instance, in risankizumab, it could be seen that there was a prolonged effect of one dose, and it was considered that this was a characteristic of P19 antagonists. We saw that with risankizumab and guselkumab, there was a significant population of patients who remained on PASI 90 for a long term, far beyond 7 half-lives. So this somehow suggested that there was some change that took place in the genetic or the cytologic background or underpinnings of psoriasis. And with guselkumab, it was seen that there were some predictors of remission, such as the short duration of disease, the low body mass index, the high serum levels, and early complete clearance. So time to relapse after discontinuing systemic treatment for psoriasis is well known that is longer with P19 antagonists. It's shorter with IL-17 antagonists, and it's even shorter with etanercept and other drugs. But now we know that this remission induced by drugs which are able to achieve the highest percentages of complete clearance is not specific or a characteristic of guselkumab, risankizumab, botiniracizumab alone, but can also be seen with some other drugs from some other classes, such as bimekizumab. So there's that background of the remission and delayed relapse that seems to be more likely to occur when the duration of the disease is short, when the baseline body mass index is short, when the concentrations of the drug are high, and of course, when the complete clearance occurs earlier. And the ECLIPSE trial provides some evidence that there were some differences which might be related to the drug in terms of the concentration or the presence of tissue-resident memory cells and Tregs, and this led to the development of mechanistic trials. So this is the ECLIPSE trial in which guselkumab and secukinumab were compared, and it was seen that after some period of time, the guselkumab retained its efficacy. But what was interesting to see is that there was a difference in the content of tissue-resident memory cells and T-regulatory cells, regardless of the response. So with the same degree of response, patients treated with guselkumab had lower levels of tissue-resident memory cells, whereas patients treated with secukinumab had lower levels or lower concentrations or numbers of T-regulatory cells. And this might explain, I might provide an explanation as to why patients on guselkumab are able to retain their response for a longer time. And then there was the concept of super response, understood as early clearance. There's an association between super response and remission, and also on dose reduction. And it has been associated to a short duration of disease. Does this mean that early treatment will lead to super response or remission? Well, there's the STEP-IN trial that shows that when we compare secukinumab versus ultraviolet B in patients with new onset psoriasis, that is psoriasis with less than 12 months of evolution, who deserve systemic treatment, and that's not so easy, there's an improvement in terms of the response that can be achieved by secukinumab. But the most important conclusion of this study is a mechanistic sub-study that took into account patients with short-term duration of the disease, it's like less than 1 year, or patients with a longer chronic disease that was more than 5 years. And it was quite interesting to see that the normalization of the transcriptomes of inflammation occurs faster in the new onset than in the chronic cohort. And the GUIDE trial also has provided some rationale in that respect. So we take super responders. This is defined by PASI equals 0 at week 20 and 28. And of course, this depends on the frequency of administration of guselkumab in this case. And we saw that this has been just published, that the patients with less prior biologics received were more likely to achieve the super responder status. And on the other hand, patients with a shorter disease are more likely also to achieve that super responder status. And this in the GUIDE trial, the goal is to see the eventual response or the differences in terms of the ability to lengthen the interval, and also in terms of achieving remission. It is quite interesting to see that these patients in the GUIDE trial, at least 40% of them had to have a disease duration of 2 or less years. And on the other hand, these patients had a mean PASI of 18, a body surface area of 26. So these were patients with a very severe psoriasis that had been developed very quickly. And of course, these patients who achieved super response status, again, were younger, less psoriatic arthritis, less obesity, and less burden of systemic therapies. So again, a pattern appears. But early can take different exceptions. What do we mean? Early from diagnosis, despite minimal severity, should we start treating patients with a very localized disease that could be treated with topicals? Or do we mean early from the initial need for systemic therapy? Because as soon as one patient requires systemic therapy, I completely agree that we need to provide the most effective treatment available. But still, let's remember that the patients in the GUIDE trial, more than 40% of them were what in Spain we call green dogs, oddballs. They were patients who, starting with psoriasis in less than 2 years, had achieved a mean PASI of 19, and that's not so commonplace. So the results of these kind of trials cannot be generalized. The current proposals are that the best responders maintain response, and the definition of super response is arbitrary, depends on the drug, that the short duration of disease is associated with super response, and thus early treatment leads to super response, and this leads to maintenance of response. And this might or might not be drug specific, because it might depend not just on the mechanism of action, but also on the ability of each drug or dose to enrich the cohort of super responders. So if we get one drug which early on achieves a high percentage of PASI 100 responders, then we might see an increased number of super responders. There's a post hoc ego propter hoc fallacy. Early treatment is associated with better response, but this does not mean necessarily that early treatment determines a better response and that we should treat early. The window of opportunity does not apply to diseases such as psoriasis without structural damage, as opposed to psoriatic arthritis. And what really matters is the time of treatment initiation with respect to the activity of the disease, not the total duration of the disease. The ability of retreatment to regain response when we lose it, and we must remember that retreatment should not take too long. We should start retreating patients when they get a PASI of 3 or lower. So that's my personal approach. We need to treat as soon as required, with systemic treatment, when the patients require systemic treatment, with the best, the most effective, less likely to lose response available agents. Early does not take into account the diagnosis of psoriasis, but the requirement for systemic treatment. We should aim for PASI 0 and adjust doses thereafter. That's the super responder patient, and we must be able to prolong intervals and to discontinue treatment. And when we must retreat, we do not wait until the PASI gets too high, and we should aim for a PASI less than 2 upon retreatment. That's the strength of the current treatments that are available. So in conclusion, early treatment, yes, but when the patients deserve it. Thank you very much.
Thank you, Professor Puig, Professor Iversen. That was excellent and really, really exciting to hear those two views. We have a few questions that are in the wings, and I'll start with those in a moment. But if I may indulge myself with a question first. I was really excited to hear around how there's been attempts to determine if the drug that was used might have an impact on, say, the super responder cohort, and analysis of treated skin to look at subsets of, say, tissue-resident memory cells reducing and different amounts reducing with different drugs. But if you could design the perfect trial to help answer this question going forward, these are the subjects for debate, I guess. Would you end up having any particular methods, drugs that you would include, or any particular criteria such that, you know, we get new interesting data that captures perhaps an early phase when severe patients present, for example? Are there any elements of such a trial that would, you know, give us an answer as to whether early or late intervention is really key when someone has what might ultimately be severe psoriasis? So Professor Puig first, maybe, and then Professor
Yes. The problem with late treatment is that patients have been through multiple drugs. So the more naive the patient is, the more likely it will be to get a response. So the ideal design of a trial should be to use a drug which is highly effective, is able to achieve the highest possible percentage of complete responders, passing 100 early on, and then see what happens in these patients. But the problem is it's very difficult to determine which is the control group, which is the population of patients with whom we should compare this.
Perfect. And Professor Iversen, would you add to that in any way? I guess, you know, there's never the perfect trial, is, you know, to play devil's advocate, right?
Exactly. And the challenging thing is in psoriasis, we have this huge diversity in disease severity that also Luis Puig alluded to. And that makes it difficult to intervene with very potent drugs very early on. So to do such a study would require an enormous amount of patients, and you would have to follow for a long time, because we all know that the vast majority of psoriasis patients, they have mild psoriasis. So if we put them on very intensive treatment, aiming for deep remission and early on, to do such a study would require so many patients. And that's probably the reason why we don't have the same data as they have in rheumatology and gastroenterology. As Luis said, this is a destructive disease. So you can better argue that you should intervene more potently early on in the disease.
No, perfect. Professor Puig, would you respond to that in any way, or?
No, I think that clearly said the point. I see there are some questions on the chat, and there's one about the potential, the possibility that mechanical stress, Koebner phenomenon, could somehow trigger tissue-resident memory cells. Is there any evidence in that respect? Not just on the skin. I am thinking also on the joints, for instance, on synovium or entheses. What's your take on that, Lars?
I haven't seen any data saying that, but I think that there's data supporting that if you have ongoing inflammation, that you will recruit tissue-resident memory T cells. So if you assume that you have a psoriasis patient where the Koebner phenomenon, which is probably what we are alluding to if it comes to the skin, when you traumatize the skin, that will cause the inflammation. Yes, then I think you will recruit these TRM cells into that area.
If we could go to the next question from Professor Kameni, which is, what about the role of a potential epigenetic alteration in epithelial stem cells in psoriasis lesion recurrences? So shifting that age-old argument of perhaps where it starts and what maintains it.
For sure, that's very relevant. There is a very nice publication that came out some years ago, actually now, showing that also the epithelial stem cells harbor some epigenetic changes that causes a kind of disease memory. So this is absolutely a relevant topic to bring up. We don't know very much about that in psoriasis, and because of the limited time, I could only mention that epigenetic changes is probably playing a role, but the stem cell is absolutely a relevant source to look at as well.
Yes. Could I just ask you, Lars or Luis, a kind of a follow-up question? So if what is the evidence for linking causally those epigenetic changes to memory, whether immune or epithelial, it doesn't matter. So for example, as an alternative, could the fact that what we are looking at as memory, could that reflect perhaps some residual disease, which is just there, and when the skin is exposed to any kind of trigger, then the disease is just reactivated, but there is not, but those epigenetic changes have actually nothing to do causally with the reactivation of the disease. So how do we prove from a scientific experimental point of view the causal role of epigenetic changes as underlying this memory we are discussing today?
We are very early on in discussing that in psoriasis. So this is something we have to follow up on. But I think that the publication that I just briefly mentioned, the one showing that there is this AP1 transcription factor that is part of the epigenetic changes, where you have the Jun, which is part of the AP1 transcription factor, being there ready for reactivation.
I would think,
shown in psoriasis to have an altered regulation. And in the same publication, they also mentioned STAT3, which we also think, or also have seen, that is altered in psoriasis. So the transcription factor AP1 and the STAT3 in this paper was shown to be part of the early activation based on the epigenetic changes. And they are definitely known to be part of the pathogenesis of psoriasis. But this is indirect proofs, so we don't have the final proof yet, but we are accumulating data that support it.
An alternative view could be that epigenetic changes in epidermal cells might be more related to the innate arm of the immune response, or the production of antimicrobial peptides and the like, as compared to tissue resident memory cells that seem to be more, might link both arms, but might be more related to the activation by interleukin 23 of IL-17 and IL-22 release.
Thank you.
To that, I think it's important to say that if we look to the history of psoriasis, we started out thinking of psoriasis like as keratinocyte-driven disease. Then it was all about the T cells, and now I think we all see it as a vicious cycle where they are interrelated, the keratinocytes and the immune cells.
Thank you both. I'm going to raise another question from the chat, which invite either of you to respond to, and that is from Daniel Sorterbach, and it's from the Stockholm psoriasis cohort. Professor Iversen talked about up to 15% of patients experiencing spontaneous resolution after 10 years. Yeah. Are there any theories as to why some patients seem to improve in their skin with aging, while some seem to develop more severe disease?
It might have to do with immunosenescence. We don't have a real comparator arms of patients who remain untreated, so it's difficult to prove, but in my view it must have to do with the immunosenescence in those patients.
And Professor Madsen, would you add to that?
Yeah, I also think that we tend to think of the psoriasis patient as one uniform population, and we know that there are 100 genes that are associated to predispose to psoriasis. So I also think that the genetic signature, so to say, can play a role here. And there are some, we know that there are some that get flares in psoriasis when they become stressed, if they have the psychological stress, whereas others doesn't. So this is not such a uniform cohort. So there may be a subset of patients where other factors come into play, and I think that could be a result of that.
Perfect. Ellie, in the interest of time, I don't know whether we can still take the last question or whether we shall move. I appreciate how precious the time of everyone here is.
We can get a quick question, provided we get a very, very short answer.
Okay, so the last question is from Professor Sonkoli, who says, how can you really differentiate whether late treatment is less efficient because of 1, the long disease duration, or 2, the modulation of the immune responses by several previous systemic or biological drugs?
the issue of biologic fatigue is very important and highly interesting, because sometimes some flares can be induced by external drivers, but then on occasion we can see fatigue. And it might be the case that some phenotypes might change as a consequence of the modulation by the different classes of biologics that or treatments that we are using.
Perfect. Thank you, Professor Puig. I would just like to conclude to thank both the speakers. That was a fantastic overview, stimulating many thoughts and discussions. Clearly, there's some questions that can never be answered, but I think continually these clinical problems will prompt new research questions, and that will keep our community excited and looking for new ways to explain the phenotypes we see. So I thank you both. I would like to complete our kitchen today by again thanking Bristol Myers Squibb for supporting this event, which is really fun and exciting, and to highlight our next kitchen coming up on the 15th of March, where we will hear about zebrafish as a model, as a new tool for skin cancer research from Elisabetta Palazzo. And finally, these pieces of content you can catch up later if you haven't had the time today. They're all available on the ESDR website via YouTube. And of course, in a very short time, hopefully we'll all be enjoying each other's company in person after a long time of not seeing each other in Amsterdam and hopefully in Tokyo. And please submit any late-breaking abstracts. That window opens from the 1st and 31st of March. And with that, I'd like to thank our speakers once more, our sponsors, and the ESDR. Thank you all.
Thank you.
Thank you.